Welcome everyone, my name is Stuart Hinds. This is a demonstration of my ARI or NAT hip technique. Here we have the wonderful Tom. He's an ongoing client of mine. This is obviously a maintenance treatment, but this gives you a representation of how this technique works. Tom came in with right lateral hip pain, right lumbar pain, and also groin pain as well, to the point that he had almost been diagnosed with a potential FAI, for those of you who are familiar with that, which is the femoral acetabular syndrome. On first assessment, I noticed that he had global restrictions in both his spine, but also
yeah, it makes sense.
So the process works like this. First I assess the hip extension component, trying to draw out wherever he feels the current restrictions. This is probably about the fourth treatment in this stage, and as you can see at the moment that Tom's feeling just a little bit of a pull through both the ilio-lumbar ligament area and also just that gluteal, but still just a minor amount of restriction through the anterior portion. And that's probably the common thing that I see. This is where this treatment technique sort of comes into its own. After years and years of applying a whole range of different types of techniques to try and unlock soft tissue restrictions in the hip, the first thing that I've seen in most hip dysfunctions, not specific that is that there's the lower iliopsoas trigger point, just above the ear, seems to be the major restrictor there. So as we're applying a digital ischemic type sustained pressure, and what we're actually looking for here is the giving away, if you like. The second restrictor in this will also be the rec fem, and I often see that as the common theme as well. So Tom came in, he's a triathlete, and he's also an ex-footballer as well, and he also surfs as well. So these are the activities he's coming to. He's transitioning out of football into triathlon, which he had a history in triathlon many years ago. So Tom was obviously feeling quite restricted through this hip as he was getting back into triathlon training, especially the running and so forth, not so much as the cycling. He's quite an avid and very good swimmer, so doesn't really have many issues in the swimming component, so it's primarily the running component. And what he was coming in with was just this one-sided or unilateral sort of symptomatic signs for groin, lump spine stiffness, and then obviously just this global restriction through his hip. And he'd obviously had some other treatments beforehand, and nothing seemed to work or unlock and so forth. But as we worked through this process, even after the very first treatment where we offloaded his adductor magnus, a lot of that overwhelming gluteal pain had dropped, or that gluteal tension had dropped right away. And that's also one of the common denominators of this technique as well. So how it works for us is that we work through these restrictions in relation to hip extension, and then we work through the hip abduction restrictions, and then finally the combined of internal and external rotation, and we just chase those restrictions until they're plotted out. So as I said, Tom's coming in, this is his fourth treatment, so this is more of just a maintenance and a bit of a tune-up, if anything. The first treatment was a lot more comprehensive in terms of sustained pressure and so forth. So we can work through these restrictions quite easily now, because the body's starting to assimilate and it's starting to feel like this is the normal pattern as before. These old movement patterns, not all necessarily the case. Keep in mind the reason that I developed this technique was in relation to the NAT technique that I used for the frozen shoulder and obviously working through those frozen shoulder dysfunctions. I'm thinking, always connected to the hip. So it's through that process that this technique. So we just worked through the second restrictor here, which is the rec fem. As you can see, nothing fancy about these techniques. It's just more the application and the sequence of it, and more of a methodical release type scenario. Through all of this treatment, obviously engaging in time and how and why this works and so forth. Tom's one of these rare clients who gets really intuitive in relation to his own body and how it works, which is fantastic. Makes your job just that much easier. So sustained longitudinal gliding up along the rec fem all the way up just past the attachment is the release technique. Then I will put him into a lengthened position and work through the rec fem itself. Once again, they're not fancy techniques by any stretch of the imagination. I'm not trying to reinvent the wheel by any stretch of the imagination. As I said, it's the application and the sequence and the assessment that makes all the difference here. And, I'm not a big fan of reinventing wheels. It's more, it's got to be consistent changes and certainly effective changes as well. So here we go, popping it into a bit of knee flexion. So just to put that rec fem on a little bit of a stretch, and then we'll obviously work through that range of movement through there, and as you'll see, trying to pick up any of those restrictions as we work through. Usually that midway point to the higher point that I found on Tom, that's where most of his restriction is. That does obviously be consistent with a lot of the hip problems, whereas when we start to deal with hip and patellofemoral stuff that I do see as well, some of that will be more related to the lower part of that rec fem. But work all the way up, and obviously what you'll probably find is nestled in just near that iliopsoas trigger point, just below that, and just a little bit more medial will be the rec fem one, which is an all-time favourite as well. Don't class the rec fem one in the super trigger point status, but I certainly put it in the treatable one, and it does just provide that next stage of restriction release, if you like, for that anterior hip and for the hip extension component. Alright, so at this point we turn Tom over, and what we'll do here is we're going to do obviously some subsidiary work just through some of the gluteal fascia and also some of the gluteal trigger points there as well. We start off in and around, not far off the iliolumbar ligament actually to start with Tom, because he has had a history of iliolumbar irritation beforehand, and for any of you that have been in any of my postgrad workshops, you'll know how much I love the iliolumbar ligament. Absolutely pearler of a little region in terms of restriction, and none so more when we're looking at hip extension restrictions. So yeah. So we're going to do a little bit of work just off the glute med now, that trigger point that wraps up and around the lumbar spine itself, and that's something that we see with Tom. And I think what flares this little component up for him sometimes is the fact that when he's up surfing and so forth, and he's got that right foot forward, and as he leans back into the wave, that's obviously where a lot of that tension comes. What it also does is it brings in that pectineus and a little bit of that adductor longus and magnus as well, trying to counteract that. So, I used to spend a lot of time on the gluteals, especially glute med, and especially if we're talking to runners, football players, soccer players, and anyone who's obviously running part of their activity or their sport, and dealing with extensive and restrictive overload or load management to this gluteal component. And sometimes, you get the big changes, and a lot of the times, it feels good for a small amount of time, but that load tends to come back very fast. So I suppose the piece of resistance, if you want to call it, for me was the fact of when I was working with the NAT technique for the shoulder, obviously what we're looking at is trying to engage in a lot of the antagonist and agonist relationships, and obviously if that main prime mover was restricted, looking at maybe offloading a lot of the trigger points, or the main trigger points that oppose that muscle, and seeing how much, or if it would make a change. And for the glute med, absolutely no doubt, once I started applying these techniques to the adductors, and whether it be longus or magnus, obviously magnus is probably the main form there. We're starting to see considerable drop through that gluteal load, and also basically the hypertonicity, and that's what's made all the difference. So look at that hip extension. Okay, obviously we all know that the driving force here is the glute max and the erector spinalis, and also that biceps fem. But if we look at the anterior opposing muscles, and obviously the restrictor there is going to be that iliopsoas. And because I'm not a big fan of the iliosoas work through the abdominals, I've always found that I've been able to make much more consistent changes and greater changes by releasing at the anterior hip, especially on the Thomas test, the modified Thomas test, and also on just this prone hip extension component. So and that basically sold it to me. Not trying to get the changes on just the once or twice here and there. It's got to be a consistent change all the time, and that's something that I tend to see. And Tom's no stranger to this, because as he got off the table after we did our first treatment, the feedback from him was quite overwhelming in the fact that, oh my god, that's the first time I've never felt restriction in my glute, and that's been a long time coming. So here we are, just doing a little bit of hip abduction restriction here. Now we're just offloading the glute medius and the minimus. No doubt we still need to do a little bit of work through these muscles, absolutely no doubt, but then we move directly straight into the hip adductors, and as you'll see for Tom, pretty sure you'll see that adductor magnus is his biggest restrictor. It can also just be the adductor longus, and sometimes I even see the pectineus and the pyramidals as well. So it's all individual, but we certainly need to take in place somewhere along the line those opposing muscles.
Crucially, they change colour with the seasons, darker in summer and lighter in winter. The theory was that the darkness was caused by water when it was warm enough to allow the super salty water to flow. And after years of painstaking work, observations and analysis, that's exactly what they found.
It's obviously ridiculous that salty water, so yeah, absolutely. I don't really know any answer about salty water. No.
In 2011, there were some dark features on the sides of Martian mountains that were changing with time. They sort of looked like figures flowing down the mountain side.
But looking at a picture taken from an orbiting satellite wasn't enough. Rachel Webster says the researchers got the proof they needed by analysing the dark areas from space and discovered the presence of a salt called...
So here's the release work for the iliolumbar ligament. A little bit of sustained pressure here. Don't really need to be doing an enormous amount here. Probably in the vicinity of 30 seconds to a minute, if that. Then we move off here, and we can do a little bit of work just in the one or two of the trigger points of the glute max, and then we'll move on to the hip abductors. Adductors.
So this glute, this is a little bit of your nemesis.
they would follow the more.
I think like getting on a tennis ball and stuff like that would be good for it.
Yeah, but this is where the adductors are so important.
Yeah.
Whether or not there would be
Because they oppose each other.
Yeah.
So
Okay, so we take Tom through.
Muscles, you never get.
You never get a release point.
Yeah, correct. That's
Hip
why
extension again, just to see if we've made some changes.
So I just everything feels like it's back on play.
And straight away what we should start to feel is there's absolutely no restriction through there in either the glute, lumbar spine or the anterior hip, and that's what we're looking for that plateauing out.
Yeah.
It'd feel like it was
And
I definitely
making sure that we're reducing
stretch my adductors before I stretch my
any
glute.
potential
I get
restrictors
sometimes
there.
relief. Otherwise, if I just go stretch my glute, I end up hurting my adductors.
Yeah, correct. Spot on. Right, spin over your back. You're a classic example, mate. That is exactly what, you know, yeah. Which, in some respects, intuitively for you, whilst you've been playing footy, if you've been doing that, that's been able to allow you to probably play as long as you have without having
a major injury.
Yeah, because the problem is with that, when that doesn't, you know what it's like when that doesn't work. Can you imagine if you're a triathlete or you're running a marathon and you've got fatigue starting to happen in that glute because of that in addition? That's when you start developing knee problems, calf problems and all that sort of stuff.
It's been obvious to me that it's like my body's like a freaking puzzle. We've been working it out. Everyone's been working it out slowly, haven't they?
Yeah, and that's where your chiro's coming in, you know.
But there's still been something before the chiro.
Yeah.
Like this is obviously the chiro never saw any of this. Since I've been seeing
so it's at this
I saw
point
the
now that
chiro,
we
right? Saw you first.
start applying some
and you're like, yeah, there's something not right.
technique to the
When saw the chiro, she might have got that.
hip adductors.
And the chiro hit
I'll
all
explain to Tom
So
here,
I
obviously
started
the
seeing
relationship
you, I've
between
gone through
glute
another
and knee,
progression. And then I went back to the chiro.
Dr. Magnus with the
she's like,
Dr. Longus and
I need to
so
see you for the
forth.
next
So
3 weeks.
what we do here is
Now
that
she's
we
working
put the
on
hip
knees back. So she never saw that.
into
So she's picked up on
flexion, and obviously
by working with both of you, it's definitely
adduction.
Yeah.
Okay, so we've got the muscles on a stretch,
I can
and
tell when I wake up
what I'll
in the
do
morning,
is start to apply longitudinal
I can run
body
now in the morning.
along the adductors, but what we'll do is we'll search all the way through until we hit the adductor magnus trigger points, up high, right up, as you'll find in that ischial tuberosity component there. So there's two there. So working through the upper half of that adductor magnus there to get that main restrictor there and offload that.
I've only got one person to blame to get myself in this predicament. It's not like I had I was going to say Ashley. Like I've been very lucky. I've never had a torn knee or anything like that. I've just take my body for granted and let it sort of build up and build up.
It's what most people do. Actually, I'm just as guilty with that as you are.
Yeah. Well, I think my body was basically telling me, stop fucking doing it. From the point where I couldn't sit for 3 weeks and because I had nerve pain, that's enough of a lasting memory.
Correct.
Yeah. Not doing it again.
It's just
it's
so much better.
I know.
You were up here when we first started, you know, so
it's amazing.
So here we go in relation to assessing the last part of the restriction in the hip, and that is the passive internal rotation. So for Tom here, we find the posterior fibres of TFL. Not surprising that that's a restrictor for their internal rotation. This is the individualised part of the highly individualised part of this, because obviously this can be associated with restrictions at the iliopsoas attachment. It can also be related to the rec fem. It can be TFL. It can be the deep external rotators, and it can also be the adductors. And I classify this last part as the chasing the restriction. So we may work through a couple of those sites as we go through, but for Tom, we're just looking at offloading that TFL. And that'll make up the last part of that the treatment process.
and you start doing footy, and then you do running to get yourself fit for.
Should mention that probably the first treatment that you may do with a client with this type of technique is the fact that there may be several sites of restriction as you work through this internal rotation, and what you're actually looking for at the end of the day is obviously an increase in range of movement. There's no doubt about that, quite a considerable one, but at the same time what you're looking for is what I classify as a plateauing out, so where they're looking at it and saying, oh, I'm really struggling to tell you where I feel that, and that's what you're looking for. And then as you work through a series of treatments, 3 or 4 treatments, you should start to pick up the pattern quite easily, and you'll be left with just the one restriction there as you work through that. So I hope this gives you great insight to how this technique works. I mean, this is about as case study worthy as I can give you. The technique itself is probably at its best when we're dealing with the athletic hip, so obviously as opposed to someone that sits at a desk for long periods of time, but as you'll notice as we work through these restrictions, there's absolutely no substitute for great assessment, because the whole treatment is based around your assessment procedures. So make sure you employ those. I hope this gives you, as I said, a great insight into the technique, and obviously I'll be demonstrating this at the workshop later on this year with Simeon, give you some insights to it, and obviously there's a lot more underpinning knowledge and technique to it, but this gives you obviously the insight to it.
Exactly, but he was little and he was sort of like not that aggressive. Mine was in the middle, but when it went, it was sort of a bit scary. And Jake's is sweet. Like Jake, the youngest, is a psychopathic killer. Yeah. I think I met Jake. Oh, when he was growing up, he's chased Brooke and with knives and bats and stuff like that. Like when his switch gets flipped, it's on. Yeah. So but he is the most placid and quiet. So if it's a bit flipped, when it does. But that's the thing. You got to watch the quiet ones. That's what they say, don't they? They do say that. Yeah. There's always. Yeah. That's 5. Best like grandma's speech. He didn't have a piece of paper or nothing. Like he just stood there. He's only a young guy. Stood there and just answered the questions on the camera. You could see him think about it. When he thanked everyone, he didn't really forget anyone. You could tell. Did anyone get close to him? Not really, no. Because he got injured and didn't play the last few games too, so. He was far ahead. Yeah, he was 31 votes. Not many people have been on that, have they? No.